This is Gina Mauricio with A.T. Still University Functional Biomechanics. I'm conducting my biomechanical analysis project on the running stride and injury risk associated with it. There's a high prevalence of overuse injuries, with most scientific journals revealing about 75% of runners will develop a running injury. Combined multiple degrees of freedom about the hip, knee, and ankle-foot complex will allow for excessive movements in the frontal and transverse plane in the presence of muscular imbalances. So I'm referring to abduction, adduction, internal and external rotation, as well as eversion and inversion moments. So we're going to take a look at our subject, just to give you some background on her. She's a 45-kilogram, 50-year-old female recreational marathon runner. She started marathon training and racing during the 4th decade of life, and she has completed 3 full marathons and 15 half marathons in the last 2.5 years. She is currently running approximately 65 kilometers per week, and her previous athletic endeavors include playing softball in adolescence and high school. The subject currently runs with the marathon training group, and they train on all different types of surfaces: dirt tracks, asphalt, pavement, and trails. The subject's chief complaints are that she feels like her knees are hitting each other while she's running, pain in the gluteal musculature in the proximal area of the right leg iliotibial band, and low back pain. Now we're going to take a look at her running in real time on the track, focusing on her knee and her foot, on the right leg most specifically. Okay, so the real-time video clip went by pretty quick. So what I did is I captured these stills of her stride from the video. So the problem is in her right leg at stance, but we're going to take a look at her left leg just for a moment. If we look at the foot is in neutral position, and it's allowing for proper distribution of the ground reaction forces to the more proximal joints of the lower extremity and throughout the entire kinetic chain. That stride on the left leg there at stance is looking pretty good. So the right leg, we have some issues there. So let's take a closer look at that, at the kinematics at the right leg at stance. What we're seeing here is we're seeing some knee valgus. So what we have from that knee valgus is some femoral adduction, the femoral internal rotation, the knee valgus, of course, and we have some foot eversion abduction. These excessive movements in the transverse and frontal plane are not super exaggerated on her. However, they're still putting strain on her soft tissues and her musculoskeletal system as a whole. And we can see a good picture of this right here of the resultant variables of right leg kinematics stance on our subject. And what we're seeing is that the knee valgus is allowing the ground reaction force vector to pass lateral to the knee joint center, as well as foot eversion abduction affects the propulsive lever arm, as well as creates a deviation from the proper line of progression in the sagittal plane, shifting the center of mass. This resultant ground reaction force is going to create a cumulative strain injury. So the knee valgus places strain on structures that resist knee valgus. The integrity of the medial collateral ligament, the medial patellofemoral ligament, and the anterior cruciate ligament, ACL, will decrease over time in a biomechanically incorrect running stride and may increase the susceptibility to more traumatic injuries in the future. Another example of a potential injury caused from tensile strain on ligaments would be osteoarthritis. Now, I know that we've discussed osteoarthritis in great detail on the discussion board, so I want to make sure that I'm clear in that the current literature refutes a direct relationship between running and osteoarthritis, but the most prevalent risk factor for knee osteoarthritis is previous injury to the ACL and meniscus, and that's exactly what we were seeing in the previous slide of the ground reaction force vector being placed lateral to the knee itself, and also in our Human Movement 503 Unit 2 Module 2 required reading, we learned that greater than 5 degrees of knee valgus is an increased risk in lateral compartment knee osteoarthritis. The most common overuse injuries associated with the type of running stride that we're seeing on our subject would be patellofemoral pain syndrome or iliotibial band syndrome. Patellofemoral pain syndrome is seen in about 20% of all running-related injuries, and it's caused by femoral internal rotation, which creates contact pressure of the lateral femoral condyle and the lateral facet of the patella. And the iliotibial band syndrome is 12% of all running-related injuries, and that's caused from hip adduction, increasing tension of the ITB by moving the insertion further away from the origin, as well as internal femoral rotation, increasing strain on the distal attachment of the iliotibial band. So we want to find out what exactly is causing the problem in our subject here, and we know that the muscles are designed to move the joints. So we want to verify exactly what type of muscular imbalances she may be having to create the knee valgus that we're seeing. So I conducted a single leg squat assessment, and what we're seeing here is that she has the knee valgus and the inward trunk rotation towards the stance leg. So when we look at what possible weak lengthened musculature could be the problem, we see that it could be the gluteus medius and maximus, medial hamstring, medial gastrocnemius, and the vastus medialis obliquus. And probable tight shortened musculature, the adductor complex, the biceps femoris, the short head, the tensor fascia lata, and the lateral gastrocnemius. And as far as the inward trunk rotation towards the stance leg, the probable weak musculature would be the external oblique, the gluteus medius maximus, and the probable tight shortened musculature would be the internal oblique, the tensor fascia lata, and the adductor complex. So we want to design, or I want to design, a corrective exercise strategy to help change the kinetics around these joints. So we want to strengthen the weak lengthened musculature with 3 sets of 12 repetitions for each prescribed exercise, and foam roll and stretch the tight musculature. So we're going to do this in a progressive fashion. So in the first 3 weeks, we're going to start with some non-weight-bearing exercises that will consist of side-lying hip abduction, clamshell exercise, and side-lying hip abduction external rotation. Then we're going to carry on with 4 to 7 weeks of weight-bearing exercises that will consist of step-downs, step-ups, single leg squats, and walking lunges with reach back. In the 8 to 12 weeks, we're going to add some external load exercises. So we're going to use some cables to do some cable kickbacks and some cable lateral abductions and some single leg squats on a Smith machine. It's important during the entire 12 weeks that we're going to foam roll and stretch the adductor complex, the short head of the biceps femoris, the tensor fascia lata, the lateral gastrocnemius, and the internal obliques. Now the internal obliques, we're going to stretch that using a standing hip flexor stretch with reach back. And then also to help strengthen the external oblique, we're going to do some Swiss ball core exercises to strengthen the external oblique, and that will be done doing the pike, the knee up, and the skier. Okay, now that we're at the end of my presentation, I just want to revisit the subject's chief complaints. So if you remember, her complaint was that she felt like her knees were hitting each other while she was running. She had pain in the gluteal musculature in the proximal area of the right leg iliotibial band, as well as low back pain. The subject has sought treatment with a chiropractor for these problems, and she told me that the chiropractor rubs out, massages out her iliotibial band manually, as well as using a handheld device. Now, I'm not quite sure what the handheld device is, but she told me that she uses that in her gluteal areas in her iliotibial band, as well as does some adjustments, and that helps decrease some of her pain for a time being. However, I believe that without the strength training intervention, she is going to continue to have the knee valgus, and she's going to be susceptible to any one of the injuries that I've listed in the presentation here. And it's pretty much inevitable if we don't get her stride biomechanically correct. So our goal will be to optimize her stride through exercise intervention, and therefore will minimize injury and maximize performance. So that concludes my biomechanical analysis project, and I'll look forward to all of your feedback on the discussion board. Thank you.